Okay, I think everyone's been let in. Is that the case, Helen? Just give me a wee nod there. Yep, okay. So I'm going to assume that everyone's in the virtual lecture theatre. The nice thing is any late arrivals won't be rattling doors or having to push past people making a fuss. So I'd like to welcome you all. My name's Alan Wardaw. I'm CCIO in Cardiff and Vale, and I'd really like to thank Helen and her colleagues for asking me to chair the session this morning. I'd have been coming anyway. It's a very interesting looking agenda, and it's a big area of interest to me, and I'm trying to promote this area of interest among clinicians in my own organisation across Wales. In Cardiff and Vale, we've just over the summer completed and launched our digital strategy for the organisation. And it's based around data. The whole centrepiece is data and turning data into information and knowledge. And that's obviously what today's session is all about. This also mirrors really the national direction of travel as well. And I think that's a theme that might come up in some of the presentations today. The architecture review for health informatics in Wales last year has paved the way for an open platform approach, and that's been accepted by Welsh Government. And certainly again in Cardiff, we've based our digital strategy on that open platform approach, where we concentrate on building things, starting with the data, putting the data at the centre of everything. And at national level, that becomes the Once for Wales thing. And the Once for Wales is about data, it's about information standards, it's about technical standards, and we can move away from the landscape where there's a feeling that all the applications around the platform need to be Once for Wales, provided that they conform to information and technical standards. That need no longer be the case. So I'm certainly interested to see quite a number of the presentations from that perspective today. This also mirrors the direction of travel laid out in the Healthier Wales strategy document a couple of years ago. And the thing I've been working on, sort of trying to finish off fairly recently, is the National Clinical Framework, which flows from a Healthier Wales. And that clinical framework really describes what we're going to talk about today, and how our health and care system needs to be based on data, and using that data turned into information and knowledge to inform what we do. So the agenda ahead, I don't think the agenda has been shared with you. You can probably see it now. So we're going to start with a presentation about the use of the Data Hub and the work done by NWIS in the time of COVID. And then we're going to have a session explaining what SAIL have been using to help Welsh Government during the COVID response. And then the last part of that first session, we're going to have a presentation from Amazon Web Services, which I'm looking forward to. There'll be a short 10-minute break at about 11:10, and then we'll move on to a presentation from our guests from NHS Somerset Foundation Trust, and they're going to talk about a data platform-led approach that they used in the response to COVID. And I'm particularly keen to hear from them, because I know that they've been big exponents of an open platform approach. And the final presentation is going to be about the Networked Data Labs project from Public Health Wales. Particularly looking forward to this, because I've heard the term used and I've not really got a proper understanding of it. I've not got a full handle on it yet. So I'm hoping that by lunchtime today, that will no longer be the case. So I'm not going to rattle on anymore. I'd like to introduce our first presenter, who's Keith Howkins from NWIS, and he's going to tell us about the COVID Data Hub. Thanks.
Brilliant, thanks very much. So I'm just going to, as I say, I'm going to do a bit of a live demo, but I'll start with a couple of slides just to give a bit of a background. So my name's Keith Howkins. I work in the Information Services Department in NWIS, publishing specialist. So my role sort of prior to COVID has been designing dashboards from wide range of the data sets we hold. Work mainly in the value-based healthcare area, so we've been looking at design dashboards on lung cancer, knee and heart failure, but from March it was kind of redeployed to work on a dashboard on the COVID data. So to give a little bit of a background, so our department hold quite a wide range of different national data sets in our data warehouse. So we have data on hospital admissions, emergency department attendances, birth and death registrations from ONS, for example. Around the middle of March, we were tasked with building a dashboard to support the service in response to the COVID-19 pandemic. And we found very quickly that, much quicker than I expected, quite pleasant surprise, that a lot of barriers were broken down and data that hadn't been available to us before, both within our own organisation and externally, very, very quickly became available to us. So, for example, lab test data, which we do hold within NWIS, but our department hasn't had access to before. We quickly got access to that, and also external data. So, for example, ambulance calls data from WAST, primary care data, 111 calls data, and we also set up a few data sets specifically for COVID. So data on bed capacity and occupancy, which hospital sites filled in via an Excel pro forma and submitted this to us each day to enable WAG to help them with their sort of planning knowledge of capacity. So we had a few challenges based on that to turn that into the COVID data hub, into the dashboard. Obviously, I guess the main sort of one were the absolutely urgent timescales to get something out. Some of the data sets we had, the internal ones that hadn't we hadn't had access to before, weren't necessarily built for reporting. So the lab test data, for example. So we had our data warehouse team having to do a lot of work creating views on top of the data, so we could put them in the dashboard. There are different sorts of data flows coming in. So I mentioned Excel pro forma, we had data coming in, but also SQL to SQL transfers, and different data sets were refreshed at different times. And with the new data sets, obviously there's a lack of familiarity within myself and within the rest of the department, to be honest. And also a lack of initial requirements, which in this instance is completely understandable. No one really knew what was going to happen with COVID and what would be particularly helpful at the time. So it was more a case of trying to get something out there as quickly as we could, and then tweaking that based on people's feedback. So I'm going to go now and try and do a live demo. So the COVID dashboard went live at the start of April. It's building a package called Logi. Initially, we were looking to do it in Power BI, but we had some licensing issues with that. So we went with Logi, which had another sort of challenge. There were only 2 or 3 developers within our organisation who was trained up in Logi, but we managed to get something out pretty quickly. The COVID Data Hub has this front page, so it's split into different areas of healthcare, I guess, so unscheduled care, primary care, secondary care, mortality. And then the user would click one of the areas they're interested in and see the reports underneath. But the main report I'm going to show you to start with is a summary report, which looks to pull together some of these main data sets and show the analysis from them on one page. So fingers crossed it won't crash. So here we go. Here's some different visualizations using the different data sets we had already, the new ones we had coming in, and the ones that were sort of specifically built for COVID. So the first 2 in the top left corner are from our LIMS data. That's the one I mentioned, the lab test data that we had within our organization, but not available to us initially. So these just show the number of positive tests and positive tests per day. So we can see the recent sort of second spike, the increase there. And the concept is that the user will then have a look at an area they're particularly interested in and be able to drill down into underlying reports based on those. So, sorry, I should mention as well, at the moment this is an all Wales basis, but you can click here to see different figures for each different individual health board, and the title changes at the top there, so you can see what you're looking at. So yeah, so the user would then select a certain area they're interested in and click on the graph to drill down into a more detailed report based on that. So this is a slightly more detailed report on positive tests. Loads up. So we can see number of positive tests against the number of tests carried out. So we can see there, I guess, that if the increase in positive tests is because more tests are being carried out, or it's just more people getting COVID. We've also got number of positive tests per day and tests carried out per day, and splits by health board and split by age. So one of the interesting things when I sort of going through this, visualizing the data, is pretty much for each individual health board, the highest proportion of the positive tests were in that 50 to 59 age group. Okay, so we've got another level of geography below health board level, which I guess is becoming more important now. So we've got a report on local authority data. So this graph shows each individual local authority as the whole, the number of tests as the whole bar, and then the maroon bar is the position 30 days ago. And the table on the right shows the increase from 30 days ago. So you can see the local authorities that have had the biggest increase over the last month. And it's quite interactive, so a user can put in their own time. So it doesn't need to be 30 days ago. They could, for instance, 15 days ago, and then use these buttons to see the different areas that are increasing at different rates. Okay, so if I go back into the summary report. And take a little bit long to load. That was another one of the challenges, I guess, because of the urgency of the time scales. Maybe not all the sort of SQL behind it was the most efficient. It was a case of getting stuff out there and then looking back afterwards. So the graphs in the top right are from the data set we had set up specifically for COVID, based on capacity and occupancy data. And then these two graphs below that are data based on a national data set that we've had access to for years. So this is based on emergency department attendances. So there's a theory, I guess, at the start of COVID that ED attendances would drop because people are avoiding going to emergency departments, and also less people are going out and getting themselves in situations where they'll need to go to A&E. And we can see from these graphs that that's absolutely borne out in the data. There's a big drop around April. The blue area is the current year, and the grey line is the position is last year. So you can see there's a big drop compared to last year. And again, we can drill down into the sub-report there and see it for each individual health board. It loads up. Sorry. There we go. So we can see the same pattern is borne out at pretty much every emergency department within Wales. That drop around the start of April, and then a steady increase since then. Go back to the summary page and show a couple more of the data sets we have. So another new data set we had coming in was on 111 calls that were answered. So we can see here the number of 111 calls answered for COVID and non-COVID related symptoms from March to date. We also had data new coming into our department with our team specifically on GP appointments and on ambulance incidents. I'm waiting for this one to load the out of hours cases because this is quite an interesting one. So we found the out of hours cases data was probably the best early warning sign of a peak in COVID. So there we go. We can see here, sort of around March, the start of March, a big increase of out of hours calls for cases where they had COVID-related symptoms, so respiratory symptoms. But it wasn't until sort of a month or so later, at the start of April, the number of positive tests sort of showed that big increase. So, and we can see here for the end of sort of September, we're sort of starting to see a little increase there. So that appears to be sort of a very sort of good early warning sign of peaks and rises in COVID. More bits and bobs to show. So another one of the new data sets that we had coming into us was on ambulance incidents. So this is data from WAST. Initially, it looks a bit cluttered, but one of the most interesting things I found from this was looking at the ambulance incidents. We turn off the others, but just looking at the number of ambulances who arrived at the scene, but the patient wasn't then conveyed to hospital. So we're seeing a big increase around the start of, or around the middle of March and the start of April, of the number of ambulance incidents where the patient wasn't actually conveyed to hospital, and then it dropped subsequently from there. So a couple of more things to show. One of the main areas that we've been looking at was on mortality. So as I mentioned at the start, we have mortality data from ONS, but also within NWIS as a whole, we have something called the MPI. So we could use that to see death registrations a lot quicker than we get the death registration from ONS. You've probably seen on the news, it's quite often commented there's a bit of a lag between death figures and actually sort of happening, because it takes a week or so for the death registration to come through, but we're able to see it in a very sort of up-to-date position due to the MPI we have. So this is the death data is a combination of ONS data and our data from the master patient index. So we can see here, these are age standardized death rates split by health board. But because we're using ONS data for this as well, we can actually compare it with data from England. So we can see the Wales picture and then compare it to the different areas in England. So obviously we've got a big spike for London, but Wales appears to follow similar sort of pattern to most of the other regions in England. And we can split this by all causes of death, COVID and non-COVID, and also place of death. So there's a big interest, I guess, in nursing and care home deaths. So we can see this for patients who whose place of death was a care home. And one more sort of more detailed view on mortality. Loads up. I'll leave that to load and come to a couple of other quick things. So one of the other things we found was when this started, the dashboard started picking up a bit of steam. People were interested in the data. They were asking for some of the data behind it. So we made available the data via a data extracts facility. So the user, if they're given the sufficient permissions, can go into the data extracts tool. There's each of the different reports here, and they're able to export or receive via email the data behind it. It's just aggregated data, isn't row level patient identifiable data, obviously, but that sort of gives them the ability to take the data from that and create their own dashboards based on their own requirements. That's still not loading up. Again, this is one of the, I guess, the issues with getting everything in there such a quick turnaround time is there's sort of delays maybe in refreshing the data, and it's not been as ideally organized as it could be. But that brings me on to my last few slides, I guess. So just to give an overview then of the usage. So we've got 1,000 registered users now. It covers the NHS, Welsh Government and Ministry of Defence, and 18,000 hits and 40,000 pages. So it's become, you know, very sort of popular, I guess, hub of data. And to be honest, my role really is just doing the pretty graphs and stuff. At the end, the main work has been our data warehouse and data acquisition team, getting all this new data in and marrying it alongside our existing data to enable me to create the dashboard on. And like I said, it's been something that's been a kind of a rush job, I guess, given the urgency of it. I think given sort of the success and popularity of it, it shows what we can do when we've got a bit more time and can organise things properly. So I'm just going to finish on a few, sorry, I'm not sharing this. So I'm just going to finish on a few key lessons. So some of these, again, are understandable given the urgency of the project, but obviously it helps to have sort of clear plan and objectives from the beginning. One of the main issues that I found, I'm hopeless with documentation at the best of times, and obviously this wasn't the best of times, so subsequently to creating a load of different SQL scripts and stored procedures and not really documenting them, I found myself having to go back and catch up on a lot of documentation. So definitely that's a big lesson learned for me, that to sort of try and make time to do that as I'm going along. It's a big help. Another one of the main lessons learned, as I said, a lot of the data sets are completely new to us, even the ones sort of internally within our own organisation. And we found a lot of instances where people would come to us directly because which is fair enough, we're displaying the data. We didn't necessarily know. It goes back to our lack of familiarity with new data sets, the answers to some of those questions. So we found it quite helpful to establish some clear lines of communication for people who are responsible for the source data. So for instance, we've had several meetings with WAST to go over the data and to gain sort of clarification on queries that we've had coming in. And finally, as well, I guess, as well as just Alan mentioned sort of a once for Wales approach, and as well as having data available for the whole of Wales, I think one of the key factors is to have a more joined up approach in terms of sort of planning across the whole of Wales as well. So we found that we had a lot of instances of different organisations maybe coming to us and asking for the same thing in slightly different ways. So I think a big sort of key, in as well as with the data in Once for Wales, is the actual planning and organisational stage and planning of requirements. So that's about it. I think that's about my 15 minutes. I don't know if anyone's got any questions.
That's great. Thank you. Thank you very much, Keith. It's always disconcerting. You deserved a round of applause there, and you'll just have to try and imagine that there was one. Maybe that's something we could add in to this platform, like they do for Match of the Day. But there we go. That's
yes.
for the future. So there's one question that's been posted. This is from Ashley Akbari. So the question is, have you used any specific methods, techniques for prioritization in order to adapt to the changing requirements and iterations to the dashboard? In other words, questions that need answers from or intelligence for decisions for government.
Yeah, so yes, this I guess goes back a little bit to the lessons there and the clear communication I mentioned. So we set up within our organisation, a COVID mailbox where people were directed to send queries and things that they required to be included in Data Hub through that. And then we had initially we had daily sort of COVID Data Hub meetings to go through those lists. Had a couple of our senior managers on the meetings who would help us go through them and prioritise what we wanted. And we also had weekly COVID meetings as well, not just the Data Hub, but the other work we were doing on COVID through it, and sort of kept a work log through that. So again, our senior managers would be on that and would be helping us to prioritise the different reports that we wanted to be showing in there, and the ones that we need to get in there most urgently. So.
Okay, that's good. No other questions come through at the moment, so that's great, because I've got loads of questions that I wanted to ask you. I was really encouraged to hear you say very early on, I don't think you used the phrase good enough, but that's what you alluded to. You knew you had to get something out there quickly, so it was that good enough, but let's iterate approach. So on that theme, which you've already talked about, I just wondered, can you actually measure other metrics around which of the charts get the most clicks and which ones are most useful? And if so, which ones are?
Yeah, absolutely. So yeah, we've got audit logs for the data. I think we found that the most popular ones were the mortality data. That was a big thing, so that's why we concentrated a lot of work on that, and the summary report as well. And it changed a bit over time. I mean, I guess towards sort of when there was a drop in testing and usage went down a little bit, and then subsequently seen a lot of increase in people looking at the local authority data that I've mentioned because that seems to be more of a focus now with the local lockdown. So yeah, we keep sort of audit logs of the different reports people are looking at, and it does seem to sort of vary a little bit over time, as I say, as to what people are sort of most interested in.
Yeah.
Sorry, I was going to say it can be sort of dependent on what's in the news as well. Like I mentioned with deaths in care homes as well, people hear that and then that's what they're sort of interested in and click into. So.
Well, that brings me on to the second thing that was occurring to me, and this has been a thing that's been discussed in the media itself in the last couple of weeks. I'm a great believer in democratizing the data, so it's great that these dashboards exist. I wish more people would look at them and have access to them, but that generates a problem, which is people need to kind of understand what it is they're looking at. So I just wondered what sort of problems you've had around interpretation, in particular with trends, because the trends for testing, for example, they sort of seem to suggest there's a level playing field, that the testing that was being done in March and April is the same as the testing being done now, and that the numbers mean the same thing. And of course they don't. They mean very different things.
No, absolutely. We've had a few queries where, as you say, it's been a problem, people not necessarily understanding the data, I guess. A lot of the graphs, I didn't mention at the time, are using 7-day moving averages because, for example, ED attendances might drop at the weekend, same as GP calls. So we've tried to make, we have been trying to create a sort of a metadata document which will, sort of specifically say some of the definitions and some of the things to watch out for, which I don't think we've got available yet. But I guess that's kind of been the way we're looking to tackle it. We've had some queries coming in through the COVID mailbox that I mentioned. We've got a data standards and quality team within our organisation, so they've been looking at creating a metadata document that will go alongside the data hub. So that's something that we'll definitely be looking to add to kind of head off those misunderstandings, I guess, of the data.
Yeah. That's great, Keith. Thank you very much. There's no other questions come in, and we've run out of time in any case. But thank you very, very much for that. It's always the most difficult spot, I think, to kick off something like that. That's been really interesting, and your timing was impeccable.
No problem.
Okay, thanks very much.
Thank you very much,
okay,
Alan.
everyone.
Thanks, everyone.
I'm going to move on now. We have Rich Fry, who's a senior lecturer from Swansea University, and he's going to chat to us about how. Over to you, Rich.
Thanks, Alan. I've just missed the last few of what you were saying there, but I'll carry on anyway. You go to the next slide, please. So I'm going to talk about how SAIL has been used with Welsh Government and NHS colleagues to respond to some of the research questions around the COVID pandemic. For those of you who aren't aware, SAIL is a linked data system which relates predominantly to the population of Wales, and we draw in data from our NWIS colleagues, and much of the data that we've just heard described is in SAIL. But we also pull in other data from routine administrative data, education data, survey data. We also have a system for adding some contextual data using sort of sophisticated GIS methods. Okay, next slide, please. One of the key things about SAIL is that we have a system which allows anyone to apply from it around the world. All the data is anonymized, however. So in terms of producing metrics which are actionable, like the NWIS colleagues are, we're not in a position to do that. What we are in a position to do is to answer some of the more in-depth research questions which are starting to come down from the Welsh Government Technical Advisory Group and from the UK SAGE level group. We have various funding streams, but currently the main COVID work is underpinned by an MRC grant, which we recently successful in winning, and that will allows us to look at some of the real technical and in-depth questions around hierarchies of infection within Wales. A huge amount of people working towards this, and so this is supported by a load of research centres, but particularly at the moment we're looking at the HDR UK network, the Adolescent Mental Health Platform, the Administrative Data Research Unit, which is a strong policy link with Welsh Government colleagues, and there's a unit within there who supports all our work and produces its own research. Our NRIS colleagues, of course, we know that SAIL wouldn't exist without NRIS. But we're also putting in expertise around genomics and respiratory health from Cardiff University and the Breathe Data Hub in Edinburgh. Next slide, please. So as Keith has just described, there's been a huge change in how we sort of receive data into the NHS, but then the net effect that comes into SAIL as well. So the cadence of the data has increased rapidly. From a SAIL point of view, we're having weekly and daily updates of our data, where previously we would have monthly or quarterly updates. All of this is to enable research at a UK level, so to give informed policy around some of the key research questions and about understanding the disease and how we might inform how we handle it in the future. All of this feeds in via our HDR UK network to the SAGE committee, and you get a bi-weekly report on the HDR website if you're interested. But I think what this really shows here is how well Wales is faring compared to other countries. We really are punching above our weight in terms of the data provision and linked data we can provide to research and to policy. Next slide, please. So the starting point for this was to create two longitudinal data sets. We'll have a COVID data set, so all the people we're known to be alive as of the 1st of January 2020, that's known as the C20. But we also needed a counterfactual data set, so that's all those people up to the 1st of January 2016. That allows us to look at the differences longitudinally around different subsets of the population. As already alluded to, we're actually then enhancing this data, the routinely linked health data, by further data collection in care homes with our colleagues in Care Inspectorate Wales. There are some, you may have seen some of the Happen work, which is actually going out and surveying children and parents and teachers who are working in schools. And there are some other work around pregnant women and gathering sort of views from teenagers on how they feel and responding to the pandemic. All of this data that is then deposited in SAIL through a linked data, anonymized linked data system, so we can really get to some of the nuances of how COVID affects different subsets of the population. Next slide, please. So I've talked about it briefly, but the MRC grant is called Controlling COVID-19 through Enhanced Population Surveillance and Intervention, known as CON-COVID or CONCOV, and this is a platform approach. So SAIL is providing the platform for us to understand and bring in extra data from our colleagues in the genomics and COG in at the UK level, but also we're working very closely on this with Public Health Wales and the Welsh Government. What we are trying to understand is how the different infection routes and risks affect different subsets of the populations. One of the key sort of methods around that is the use of our residential anonymized linking field, which allows us to group individuals into discrete household locations. We're also developing a system where we can group people by schools or by care homes. And of course, we've got a grouping field for those in hospital. So it allows us then to understand how this disease may be transmitted in different environments and within different demographics of the population. And we can then adjust that by different socioeconomic and clinical risk factors. Next slide, please. So it's a huge team, some of which are listed here, led by Professor Ronan Lyons and David Ford. Ronan's the lead on this bid, but he really has built a team with different skill sets to help answer these questions. And it's not just a Swansea approach, people from Cardiff, but we're also using that wider HDR network to put in the relevant expertise from across the UK. Next slide, please. So just to reflect on some of the things that Keith had shown, reassuringly, we've seen similar patterns in the SAIL data. And we were producing these baselines and finding them into SAGE, into the technical advisory cell within Welsh Government. just as a descriptive view of the data, and to help us understand as researchers what has been going on, and to give them the broad-based patterns. Next slide, please. One of the key topics we're keen on evaluating is the effectiveness of the shielding list. So this is from our colleague Fatima Tabari, who she's going to be looking at how the shielding list, how effective the shielding list was using all the linked data. This is her model she's been setting up, and you can see how all these different types of data set are linked in SAIL, and it enables us to perform an evaluation of the shielding population. Next slide, please. One of the major sort of arms of research, and then Keith has alluded to already, is around the situations in care homes. There's some very sort of complex interactions with how people are visited in care homes, how workers access different care homes, and what the effect of hospital discharge into care homes was. The more you dig into this, the more and more complex you get, and there's a lot of interest in understanding what happened in sort of the March-April period at a UK level. So we're fortunate with working with our colleagues in Public Health Wales and Chris Emerson. I'm sure you will have seen, some of you will have seen the paper on he produced on that. But we've also looked at sort of how mortality has increased compared to previous reads, just generally in care homes, not necessarily COVID related, but we just wanted to understand that background trend. And that's one of the strengths of the SAIL data bank, is that we can look back longitudinally at all the previous years and get an understanding of what may have changed. So my colleague Joe Hollinghurst led on this, and you can see there is a significant increase in all-cause mortality in care homes in 2020. What we're in a situation is now is understanding why that has happened. So not necessarily related to COVID, and is it because people have not been taken into hospital, and so there's been a shift in where people have died, or is there something else going on which we need to get a further understanding around? So the main research areas related to care homes is hospital discharge, understanding the impact of the hospital discharge into an environment where there's a lot of vulnerable people. It's been quite evident from the work we've been doing in Wales, but also at a UK level, that there are some characteristics of care homes which may lead to be a protective factor. There are also some characteristics which may lead to an increase in infection within that community. One of the most difficult elements to this is the role of care home workers. I think we all appreciate they do a fantastic job, but the risk to that community is of them bringing in an infection. We need to understand how we can support those care home workers so that they are in the best place to continue doing this amazing job. Another thing that I think we want to understand is the role of community prevalence in care home outbreaks. So we know that just from a geography point of view, each care home has a local, is cited within a local community, whether it be visitors who visit it or care home workers who come in and out and back into the local community. So what role does the community prevalence of COVID-19 play in care home outbreaks? So all these kind of research questions, which we're able to answer using SAIL, are informing Welsh and UK national governments via the TAG and SAGE groups. Next slide, please. So the other major thing that we've been doing in SAIL is using the UK CERT platform to support access to a UK-wide data set. I'm sure most of you are aware of the COVID symptom study, or known as the ZOE app. This was set up by Professor Tim Spector in KCL, and it's building on some of his cohort work he's done around the twins. They quickly adapted their current system to ask people to start recording their COVID-type symptoms on a daily basis within the app. So using the UK CERT platform, which is a secure research platform developed and maintained at Swansea University, what we're able to do is take a regular and a daily data feed of all the Zoe app data into Sail and putting in an information in government's wrapper around it to enable researchers to interrogate that data, and as well as our NHS colleagues across England, Wales and Scotland. So it's allowed us to control access to it, but also to have a really rich data set which we can then perform research on. Next slide, please. So it's a huge data set. At the moment, it's 140 million entries, which relate to about 4.5 million people who regularly use the data. We were able to extract discrete geographies, so that's a lower super output area. That's about 1,500 people across the UK. Symptoms are supplied daily by users. As you can see, although there was a peak as the initial launch of the app, and naturally through crowdsourced data it dropped away again. But then again, through sort of government initiatives, so Welsh Government and Scottish Government in particular promoted the app, whilst the official contact tracing app was developed. That created more interest, but and again, it dropped away over the summer, as you should perhaps expect, as less people were symptomatic. But then again, as we've seen in this increase, it started to increase again. But generally, in Wales, we've had a pretty good response rate for a crowdsourced app. It's around 35% of registered users are regularly active over a 14-day period. There are some limitations with it, of course, with all data, and I think understanding those is one of the key things moving forward. But it does provide a historical record of non-routine type data, which may be a really important indicator for future outbreaks. There's huge amounts of data. We've only really used probably about 10% of it for the work we're doing, which I'll talk about in a minute. But there's huge amounts of data, and there's lots of other data supplied within it, including occupation, which I think is going to become increasingly more important. There's also a linked data version, which we've developed with colleagues to try and link the participants who are actively contribute to the Zoe data into the sort of more routine data. Next slide, please. So what I've been heavily involved in is producing small area maps using this Zoe data, which we've provided into Scottish and Welsh Government steering committees. But there's quite a lot of complex stats behind it, which we've developed with our colleagues in Lancaster University. But what we're able to do is produce an estimate of prevalence based on the Zoe app users. There's a paper with the full details there if you're interested in it. But I think the key thing is it's the first map of the UK, which is a small area geography. And most importantly, I think what we'd like to point out is there is also confidence intervals around these predictions. Of these three maps, the centre panel is the prediction. On the left-hand side, you have the lower quantile, and the right-hand side, the upper. And if we can go to the next slide, please. What we can produce on the right-hand side of these maps is a hotspot. So that's a probability that these areas are going to be above the national average of prevalence based on the Zoe app users. It's been a really powerful tool. I think I say the limitations around the sort of crowdsourced data have to be taken into account. But I think what it demonstrates is we can use some of these more sophisticated geospatial methods to provide real-time intelligence into policy and decision makers. If you go to the next slide, please. So some of you may have seen this. This was used by the health minister. I think this is a video carousel, so we click on it. And we've adapted this method we use for the Zoe data and applied it to the testing data. So we can take this counts by airway and it will create a probability surface across the UK of likely locations of prevalence of COVID. This is a sort of very sort of vanilla model. At the moment, this is using a very sort of standard approach we developed with Zoe. What we're interested in now is adding some more covariates in. we start to move towards a forecasting approach rather than describing what's happened. And this is seen as a priority by Welsh Government in particular, because they want to be able to get ahead of the testing data as far as they can. Next slide, please. Yeah. So there is lots of other things to do, lots of questions that we can answer. SEL is in a fairly unique position in the UK to answer some of those. Again, as we've described, the data landscape has changed massively in the past 6 months, mostly in a positive way. So I think the opportunity now for Wales to be a leader in this area and to demonstrate some of these questions and how they can be answered using a linked data infrastructure is really an opportunity here. On the other side of that, there's also an opportunity to do more comparative work across the UK. So these are kind of some of the key areas that we're looking at as we move forward. Next slide, please. Okay, this is just a demonstrator of some of the cross UK working that Swansea University and SEL are involved in. And next slide, thank you. I think that's it. Welcome to contact me for the One Wales approach, which is that's kind of the research arm of Once in Wales. If you go to the Population Data Science website, that'll be the best place to find all the updates and the contact people who are involved in that. I'm happy to take any questions.
That's great, Rich. Thanks very much. One Wales, once for Wales. Oh my goodness, all these loaded terms.
Yeah, exactly.
That was really interesting. And I've got one question that's come through to me from the audience. I can't see who it's from. Apologies for that. But can you share more information on the technology that sits behind this and helps process such large sets of data?
Yeah, so effectively we have an IBM data storage platform, DB2, which is a main storage mechanism for holding all the routine linked data. On top of that, we have an access platform, which is the UK CERT platform, which provides effectively a virtual machine, which anyone can remote desktop into from anywhere in the world, provided they've got the government's approvals. And that's how it's managed in Swansea University using the UK CERT platform. And I think if you want all the details on that or a discussion, contact the UK CERT team in there, and they could be happy to talk through in more detail.
And I liked, I think early on, you mentioned very briefly the difference between actionable data and then the sort of data that you're involved with. And this is clearly the direction of travel for the National Data Resource in Wales. What that seeks to do is to join up or link these siloed data sets in a place where it can actually be used to answer actionable data questions, rather than the linking happening after the pseudonymized process has taken place. There's another couple of questions that have come in, one from Jeff Bartlett. How could this be used for future pandemic modelling?
Is that relating to the mapping in particular?
I guess so, yes.
So I think one of the things we're understanding, the current models are always going to be slightly behind the curve because of the nature of the testing data. So one of the key things is, can we include other covariates into that modelling, like the Zoe data, which may be early indicators, or volumes of testing data, commuting patterns, things like that. And we certainly won't be able to forecast it long into the future, but if we have a strong enough sort of regression model around it, there's a thinking we can at least forecast sort of a week to 10 days, maybe get an idea of what's going to be coming into certain local geographies.
That's great. I've got one final question. I hope we've just got time for it. This comes from Gareth Jenkins. How easily available can the anonymised data be made for local health boards? Can they get access to it?
So There is a process around this, and where local health boards, NHS colleagues, and government colleagues have been prioritised access. My colleague Ashley Akbari is the best person to talk to about this. But what we set up project-specific schemas, which can give people access to the anonymised data via the remote desktop platform.
That's really useful. Thanks, Rich. I'm going to call an end to questions there. Obviously, people can email and get in touch with Rich after the event. And I'll just say that I've really enjoyed the view from your hot air balloon, Rich, and you can maybe come down now, or maybe you're going to enjoy your flight. It looks very nice. Okay, thank you very much. So I'm going to move on now to our last speaker before we have a short break. And so Andrew Jones is going to talk to us about Amazon Web Services. I've been doing NHS Digital Academy programme for the last year or so, and I'm doing another year at the moment. And certainly we had some sessions towards the end of last year about how the big players had tried to get into the health platform business maybe a decade ago, and it was probably too soon, but they're all coming back. And I did note that some of my NHS Digital Academy colleagues were getting in touch with me yesterday evening to say that they're involved in launching an Apple PHR, personal health records platform in their organisations in Milton Keynes and Oxford. So the big guys are coming back to play. Sorry, Andrew, I'm probably not allowed to speak about Apple, but you've got 25 minutes of your own now.
Great, thanks, Alan. So I'm Dr. Andrew Jones. I'm Head of Clinical Innovation at AWS. And just by way of introduction, I mean, throughout the COVID-19 crisis, Amazon Web Services, we call ourselves AWS, supported hundreds of projects across the UK, more internationally, helping governments and healthcare organisations respond to the pandemic. And what we saw was many of these demonstrated how using data in a different way can help solve some of those issues. And the reasons why partners and customers chose AWS to create these new data-driven solutions was because they were able to innovate more quickly, they were able to develop applications with more agility and then distribute their tools globally in minutes. So I'm just going to highlight 6 examples of this from the UK and internationally where AWS customers and partners have used data differently. Next slide, please. So as the world grappled with COVID-19, researchers and scientists obviously united in an effort to really try and understand the disease, to find ways to detect and treat infections as quickly as possible. And what we found was the scientific and medical evidence on COVID-19 was and still is growing at an exponential rate. So much so that it really became incredibly difficult to digest and analyze, especially very quickly. You know, the COVID-19 outbreak has been accompanied by an infodemic, described by the WHO, the World Health Organization, as an overabundance of information, some of which is accurate and some not, and that makes it really hard for people to find trustworthy sources and reliable guidance when they need it. Identifying the key insights within that large amount of information was really critical to develop responses to disease transmission and treatment, including, you know, finding a cure or vaccine for COVID-19. Now, many of you will know the Allen Institute for AI released Cord-19. Now, that's the COVID-19 open research data set, and it initially consisted of around 24,000 scientific and research-related COVID-19, SARS-CoV-2, and coronavirus in general research. And since it was made available, that core dataset has expanded to nearly 200,000 research papers and documents sourced from peer-reviewed publications. What we did was, at the beginning of the pandemic, we launched Cord-19 Search, which was built using this dataset. And this was an innovative search website powered by machine learning on AWS that can help researchers quickly search tens of thousands of those research papers and documents using natural language questions. And COVID-19 is still available, actually. So if you want to go and try it out at the web address below, covid19.aws, you can do a search of your own. We've just sort of synthesized a quick search on the screen. So if we go to the next slide. Just, yeah, great. There we go. And if you just hit enter. So, if a clinician wanted to ask a question such as, should I operate on a patient with COVID-19? The COVID-19 search would interpret that question in natural language and return all the relevant data and evidence from the medical literature that they could then use to answer that question. So do go and have a go at that. Next slide, please. And building on this theme, we wanted to create a new kind of global knowledge platform. And this was a project which was led by Imperial College in partnership with us at AWS in order to respond to this infodemic. This platform was called Redasa, which stands for Real-Time Data Analysis and Synthesis. And it was a platform developed by PanSurge, one of our partners, which was the COVID-19 surgical network made up of Imperial colleges, healthcare professionals, and academics. And this combined artificial intelligence with human expertise. And the platform allows the healthcare community to quickly make sense of this tidal wave of information and find better treatments for COVID-19 and other diseases. The platform also aims to save clinicians tens of thousands of hours previously required for manual research and analysis. This is time that can be better spent on patient care, planning, other areas of research. And using this combination of AWS machine learning services and natural language processing, they were able to build this tool which literally saved clinicians tens of thousands of hours of time. So what we used was two services within AWS, Amazon Kendra and Amazon SageMaker, and combining this with kind of human review, Redasa was able to analyze vast amounts of information and quickly extract those most important insights from all of that research. And it was built using two technologies, really, with two of our partners, Clywed and MirrorWeb. Now, what MirrorWeb does is a website capture technology which collects increasing amounts of data, combining it with COVID-19 from the internet. And then it's processed on this Clywed's data analytics platform. And James Kinross, who was the clinical lead on the team at Imperial College, said, if you want to manually analyze 500,000 documents, it takes 30 minutes each time to review each document. You're talking about 250,000 working hours. So that's been a real improvement from their perspective in finding these answers to these clinical questions from the literature. And of course, building it on the AWS architecture meant that they could build that technology 4 or 5 times quicker than previously. Next slide, please. We've also seen more organizations using COVID data to make critical decisions much more quickly as well. And this data has been helping healthcare workers and researchers and scientists and public health officials, as they try and care for patients, as they try and search for therapies, educate the public, influence policy and communications plans. And we've been working with organizations who make COVID-19 related data available from various sources, such as public records, footfall, healthcare usage patterns, economic activity, etc. And what we've done is made some of these COVID-19 related data products available on something we call AWS Data Exchange, and some of the providers are here. Now, these are all anonymized, aggregated data sets, so there's no personal identifiable information in there. And also, in order to help everyone visualize that data more confidently, we also brought together some AWS partners, Salesforce, Tableau, and MuleSoft. and they created a centralized repository of this trusted data from all these open source data providers. So you can work with the data and blend it with their own data, or you can just subscribe to those individual source data sets directly through the data exchange. And then you can use Tableau to better understand, the impact on your own organization. And we've been actively working with partners since we established this to really make sure that we gather and maintain a complete set of trusted data and adding new reliable sources when appropriate. There's also an AWS COVID-19 data lake, and this is a centralized repository of all those up-to-date curated data sets, all related to the spread and characteristics of the coronavirus and COVID-19, and that's publicly available. And if you wanted more information, if you have a look for a public data lake for analysis on COVID-19 data, you'll be able to find lots more information there. And globally, there's several efforts underway to gather this data, and AWS has been working with partners to make sure that this data is freely available and kept up to date. Next slide, please. Another great example of an organization using data on AWS to fight COVID-19 is Blue Dot. Now, Blue Dot was founded by Professor Cameron Khan in Toronto. Now, he had experience and was motivated by his experience of dealing with the SARS virus outbreak in Toronto in 2003. And he recognized that increased access to big data analytics like machine learning and other forms of artificial intelligence and digital technologies that can enable us to disseminate knowledge and spread knowledge around the world much faster than an outbreak is able to spread. And so Blue Dot built this platform for identifying emerging outbreaks. Now, current reporting of outbreaks sometimes means that we don't always get the information in the most timely manner, I would say. And the internet has been an important new medium really for gathering information about possible outbreaks. And this can be through, the world's online media, through health blogs, other forums. And so Blue Dot's data scientists and clinicians have built a platform that is gathering information on over 150 different diseases, so not just COVID, and syndromes. And this is in 65 languages, and it's collecting that data every 15 minutes, 24 hours a day. And this is obviously a massive amount of data to process. And this is where natural language processing and machine learning comes into play. And they've been using NLP and machine learning services on AWS to extract those vital pieces of information, such as the name of the pathogen, the location, the time of the outbreak, other contextual data, such as counts, case counts or deaths, for example. And they also use anonymized aggregated data about the world's commercial air traffic. And this information includes, again, is aggregated and anonymized information on all flights schedules as they're moving around the planet. Now, combining these together, the platform was able to pick up a news of an outbreak of pneumonia in Wuhan on the morning of December the 31st by translating an article from Chinese and ultimately having the machine present it to their team as a threat that they should be paying attention to. And combined with the information on flight schedules, they were able to accurately predict the top 20 cities outside of China most likely to be affected by the outbreak. So pretty impressive. Next slide, please. Another interesting area is imaging. The Diagnostic Image Analysis Group, or DIAG, at Rabeld University Medical Center in the Netherlands. So they have an open source data platform called the grandchallenge.org, and they turned to us at AWS to migrate that from an on-premises data center to the cloud. Now, grandchallenge.org was established in 2012. To organize machine learning challenges in biomedical image analysis. And it currently brings together about 45,000 researchers and clinicians from all over the world, collaborating on these novel ML solutions in imaging. And in early 2020, it was clear that it was possible, or there was a potential to use CT imaging for the diagnosis and assessment of COVID-19. And the Dutch Radiological Society rapidly proposed a standardised assessment for CT scans of patients suspected with COVID-19. They call that CORADS. And what the grandchallenge.org did, they added the functionality so that researchers could set up archives easily to share data with each other and apply algorithms to the data and set up their own reader studies to invite experts to annotate that data. And in medical imaging, many of you will know shipping hard disks across sites is often the norm, but AWS enabled the use of direct upload using our simple storage service, which accelerated transfers across sites which were maybe distributed globally. And the platform also enabled researchers to rapidly deploy a model for automated scoring of CT scans with CORADS. And users were able to upload their own data and receive a prediction on this data within a couple of minutes. So on the platform, Diag has made this COVID dataset available, a training course for radiologists on how to assess the scan using CORADS, and the machine learning is now available to all the registered users. And the system discriminates between COVID positive and negative patients from their CT scans with really high sensitivity now. And the CORADS AI has been deployed on the AWS platform and is now available to other researchers as well. And finally, we've been working with Genomics England. Next slide, please. Sorry. And yeah, so we've been working with Genomics England to support, their work in identifying the genetic determinants of COVID susceptibility to severe disease. So Genomics England, or GEL as we call them, has launched this next generation genomics research platform to play a really important role in COVID-19 research. And this research environment will transform how genomic data is made usable for global biopharma and academic researchers. I mean, it will provide the highest patient data security but still needs to enable flexibility required by research. And so GEL partnered with AWS and LifeBit, and AWS powers the platform. And the immediate focus will be on COVID-19 data and analytics, although the platform will also ultimately be used to harness the GEL's 100,000 Genomes project. And that's really focused against the fight against cancer and rare diseases. But GEL and the Genomic Consortium are also working with the NHS to deliver whole genome sequencing for 20,000 COVID-19 intensive care patients and around 15,000 people with mild symptoms. And all that data will be stored in AWS. And the intent of that platform is to really enable researchers to identify genes that can that result in patients either suffering mild symptoms or severe disease and intensive care stay. So last slide. So thank you very much. Very happy if people want to reach out to me on LinkedIn or Twitter. Helen and the team have my email if you wanted any more information on any of those stories. I hope you enjoyed those.
Andrew, thank you very much. And again, I'd ask you to imagine a round of applause occurring now. So that was fascinating. I'll probably rewatch that, I think. So there are a couple of bits that I wanted to understand a bit more about. Infodemic is a word that I'm definitely going to take away from today. I can't believe that I haven't come across that before, because it just really captures, I guess, what a lot of us were discussing early in this process, because that's exactly how it felt. It was really difficult to keep abreast of what was happening. Okay, I'm going to assume that everyone is back in the virtual lecture theatre, and we'll move on. We've got two final presentations this morning. First up, from NHS Somerset Foundation Trust, we've got Matt Cox, Martin Strawbridge and Mark Hunt, and they're going to talk about how they in under 3 weeks, used a data platform-led approach to provide a full end-to-end COVID response service. So I'm looking forward to finding out how they did that. So over to you guys.
Thanks, Alan. Morning, everyone. My name is Martin Strawbridge, and I'm Deputy CNIO at Somerset NHS Foundation Trust. My background is a specialist nursing in cardiology, and my role within the digital programme is to provide clinical and nursing oversight to the delivery of clinical systems at our organisation. My colleague Mark Hunt will be co-presenting with me today, and he is our IT development manager for the Trust. So we're looking to talk to you today about our COVID-19 rapid response and open data platform approach. Next slide, please. So just to give you a bit of background to our trust, NHS Foundation Trust, Somerset NHS Foundation Trust is one of a few trusts nationally to have merged its acute, community and mental health services. Our acute hospital is the largest district general hospital in Somerset with a bed capacity of 630 acute beds and 15 operating theatres. We also have a further 325 beds across our community and mental health settings. Last year, we recorded approximately 97,000 acute admissions and 75,000 ED attendances. And our acute hospital is also an NHS Global Digital Exemplar site. Next slide, please. So just to give you an overview of our challenges during COVID-19, primarily our challenge from a business perspective was an introduction of a clinical and operational risk in the form of COVID-19. This risk had the potential to bring with it acute pressure on our bed capacity and direct clinical risk to patients and staff in terms of the potential for nosocomial transmissions. So this posed a question to us, how do we go about coordinating our care, optimising our bed capacity and critical care capacity during such a pandemic? So as a digital programme, our challenge was to build at pace a useful tool set to support this clinical work, keep staff safe, maximise our bed capacity, and monitor clinical data such as oxygen requirements within our organisation. Next slide, please. So what do we do? The principles to our approach to this challenge was an agile co-design process, which was essentially a collaboration between our digital teams and clinicians with an ethos of iterating at pace. We looked to develop a spectrum of tools that would cover direct care, patient follow-up, and operational oversight. Our primary focus from a front line was to fit in with existing flows or introduce a flow that was value adding and required zero to low training requirements. The key to the success of this approach was to collaborate with small groups of clinicians in order to maintain a focus on producing, editing prototypes with a 24-hour turnaround on iterations, or in some instances even less than this. We very much adopted an appetite to fail fast in this process, and we were okay with that because this failure came at low cost to the organisation. However, if successful, would bring massive benefit. The solution was integrated into our trust portal, the Better platform, which was already being utilised as part of our EPMA solution, and we focused very much on a continual improvement, and this solution was taken from start to finish in approximately 2.5 weeks. We now want to share a short video clip with you that steps you through some of the solutions that we have designed and implemented. And there's some cameo appearances in this video from Tom Edwards, our associate CCIO, and Barney Kyle, who is one of our ICU consultants. So if you could play the video, please, Karis.
We have a hybrid IT environment, which is a synthesis of a number of systems from different vendors. And we needed a way of bringing data from all of those different vendors into a single point to enable rapid decision making and with complete information available by the clinicians. We have a team of specialist nurses that are providing the results notification. We have a team of research nurses who have been repurposed from their usual trials activity, who are now using our data collection tools. And then our intensive care unit has scaled and utilised our dashboard tools for the care of their extended bed base, and every clinician in that environment is using the tool, both nursing and medical staff. We'll start with the discharge results notification team. This gave us a system by which we could be confident that we had the full set of patients that had been swabbed, who had been admitted, who had not yet been provided their results. We had all of their results immediately to hand, and we could notify them and then mark that task as complete in real time for vast numbers of patients, as you could imagine. For the research team, this provided us a means for capturing data items that were not captured but were required either through the trials or through the national reporting tools in a way that would have otherwise required many pairs of hands and boots on the floor, going from ward to ward, patient to patient, in an environment where we were trying to minimize face-to-face contact as much as possible. So this enabled, but also kept staff in a safe in a way that wouldn't have been possible without this system. And then finally, the intensive care team have used this to provide an invaluable oversight tool of their expected large number of patients. It enables them to work in an MDT environment, certainly with social distancing and also remotely.
So for us, Open EHR is a mature standard which allows us to focus really on data model and user interaction with data, and providing developments that can go directly into the hands of users. It means that we can spend a lot more time with the users delivering what they need, instead of developing database structures, objects in classes within JavaScript, C++, whatever our language choose to be. So it allows us to prototype a lot quicker. Also, the end-to-end process of getting an idea is significantly reduced with the better tooling, which is a low-code approach to rapid development, which is really, really good. A lot of the team have expertise across the healthcare setting, and it's really useful for them to work with the users and share that knowledge and share ideas instead of being stuck developing classes in code.
As sort of time progressed and we had sort of new information, we were then able to pretty rapidly drop things into place to capture those other bits of data. So we sort of worked remotely with the team, and they'd sort of add in various things to the form, and then they'd come back to me, and then we'd sort of review them and then go back. But it was a very straightforward and rapid process, and to get something like that up and running and to be able to sort of tweak it and perfect it in such a straightforward fashion was fantastic. It was a pretty easy process, really. So myself, as the sort of the clinical side, we had. So Dave Chalkley was sort of coordinating things, and then we had, I think it was Julian and Mark doing the technical stuff of the actual form, and then we had David Blackwell doing the sort of data processing or sort of data capture on the back of it. So I guess what's that, four or five sort of parts of that team. But then we had sort of a bit of input from, so for example, for our data submission team to say, well, what information is it you need? How can we best present that to you? What's the exact nature of that bit of data? So we had some input from them as well. But it was that sort of interpretation of what the different requirements from those different groups were, and working together and working out how that could go into the form, and it all worked pretty well. We managed to sort of come up with solutions to all those things.
Hi all. As Martin introduced, I'm Mark Hunt, the IT development manager here at what used to be Taunton and Somerset, but now is Somerset Foundation Trust. So just to give you a bit of a background of where we've come from a technology point of view and what enabled us to be able to react quite fast during this time. So the Trust is a history of best of suite systems, but even though we've chosen or tried to choose the best of suite systems, we've not always had open access to the data. And we knew as going forward as a digital exemplar, we had to change that. And the procurement of the EPMA solution gave us the opportunity not only to buy a really good EPMA solution, but actually it was built on an OpenEHR platform, which from a technical point of view, we could see could be really powerful in regards to building a clinical data repository and really take our digital ecosystem to a new level. With new technologies, there's always critics. It's a completely different way of doing things, not just buying a point solution, but buying a solution that enables future development. So, but through forward-thinking clinical and technical team, we managed to convince the organisation to take a leap of faith. So we set about implementing the solution as part of the EPMA deployment. So from that, that's given us a good platform to build upon. And with that, what we've been able to do, as Martin was saying, is actually use the data repository to capture data, use the tooling around it to build assessment forms and other solutions really, really quickly. And what I'll do is I'll go into some of that a little bit more detail. So if we have the next slide, please. So this gives you an overview of our ecosystem that is part of what historically has really been the acute side of the organisation. But as we've now merged as an organisation, we will be taking forward out to the wider organisation. So at the core in the middle there, we have our trust integration engine that talks all the common languages, HL7, FHIR, JSON, custom APIs, etc. And that's really key for continuously exchanging data, not with just the OpenEHR system. Oh, there we go. Not with just the OpenEHR system, but all of our other systems that are included within this ecosystem. On the left-hand side, we've got our best-of-breed clinical systems. That's not all of them. That's just some of the key ones. I think one of the ones that I will call out here is Patient Track. So Patient Track is an observation system. It does do other things as well, but we've implemented it for observation. And the rollout of that actually began at the beginning of the year, and then COVID struck, and it was a decision point of do we stop that or do actually we continue to roll forward with that. And the organisation took the decision that having observation data was really important. So we rolled that out. That is now live across the organisation, and we're able to pull that data into the platform. So Better Portal is what I refer to as the clinical cockpit. So that's where we're trying to drive initial clinician viewpoint of data, and then from there branch out into those specialist systems where it's appropriate to do so. As you saw on one of the slides earlier, we implemented Power BI. It was a tool that we had available. It was something that we had skill set for, so it was just the right choice for us. On the right-hand side, you can that's really about our wider integration. So we've got the Somerset Integrated Digital Electronic Record, referred to as SIDR. We've got the mental and community systems, which now as part of the merger, we're actually starting to pull that data into the platform, as well as some of the other national systems like GP Connect, Mesh, etc. I think just from a technical point of view, my final point really is clinical services change. Open EHR platforms and solutions within our ecosystem do not just directly provide an answer to the clinical needs today. They enable the ability to provide solutions for today, tomorrow, and future needs. And I think from a technology point of view, that's really key. So just from learnings and what we need to be able to do going forward, obviously we've got a highly flexible, capable platform there from a technology point of view. And kind of the theme for today, really, we've also recognised, and that's the ability to prototype fast, fail, and iterate directly with clinical people and technical people, and just bring those teams together directly, working together. One of the stats that we had 83 iterations of one of the solutions in 48 hours, which is really, really high, but that was due to that direct engagement. And that's the sort of thing that we want to take forward. We've been clinically led for quite a while as a digital program, but there's further recognition that actually, that direct integration of clinical roles within the digital program is really important. And we've also learned that, we're not just producing desktop solutions, we need to produce mobile solutions and actually put the tools directly in front of the clinicians in line with their processes, not try and build their processes around digital solutions. And really, we hope that this will accelerate our transformation journey as we come towards the end of the digital exemplar program. But from our point of view, that's not the end. We've still got a lot of work that we need to do. Next slide, please. So any questions? I guess they're all down to me to answer now.
Yeah, unlucky. You're on the spot, Mark. But thank you very much for that. And it does mean that you can receive today's prize. Acronym of the day is absolutely cider. I just can't believe that you got away with that one. But that was really interesting for me. I don't know, colleagues that are on this call or in this meeting from Cardiff and Vale. That's really that's what we're trying to produce as our digital strategy, the approach that's just been described here. And I'd like to think it's what I still think the direction of travel in Wales is. The architecture review of last year, I think, is describing the model that you've put forward here as our way forward. It just sometimes seems to be a bit slow pace. I certainly know that colleagues in ABHB and BCU share our feeling in CAV that not necessarily the specific products, I hasten to add, but the architecture and the approach that you've taken here is the way forward. One of the things I was really pleased to see, you talked about having clinicians, developers and analysts all working as a team. And that seems to be, from what I've been able to, lessons we've been able to draw from other healthcare systems internationally, that seems to be quite important in getting your data into a state that it can be turned into information and then actually being able to understand it and actually making it into something useful that you can use to iterate the system and do things differently. I've waffled enough there. I've not seen any questions come through. I'm sure there will be some questions. I think we've just got quite a shy audience today. And again, I think contact details will be made available. I'll just warn you in advance that when the times permit, I certainly plan to come over to Somerset and Taunton and renew acquaintance with Mr. Chalkley and his colleagues and just find out a little bit more detail about what you've been doing in Somerset. So thank you very much.
Alan, we have a question.
Oh, we do.
Just jumping in.
I missed
We
that.
do.
Sorry. Right, here we go. How did you avoid vendor dependencies? Was it difficult to break away and or get the best products? And that's from Gareth Jenkins.
That's always a difficult thing to do. You know, from my point of view, coming from a technology point of view, I suppose I've always had quite a small voice. Everything's chosen on how flashy it is from a clinical point of view, and rightly so, really. It needs to be able to deliver that clinical function. What we've tried to do in the latest round of procurements is actually look at how the underpinning and bring in a wider set of requirements. And some of those are specifically around, you know, just having the APIs to interact with the data. What we're not trying to do is specifically impose that systems must be built on this technology and work in this way. What we're saying is, if you want to have your system within our ecosystem, you must have the ability to exchange data. And that's really what we've been focused on. You know, a lot of these systems are still built on SQL databases, have their own custom front ends, etc. That's fine. But let's have the data, let's pull it into the repository, and the data is ours to control and do what we want to do. And just on that proprietary front, yes, we are, you know, we have chosen Better as a partner, is part of this, as a very strong market leader within OpenEHR. But we're also working with a lot of smaller vendors now that we have the clinical data repository to build solutions, and some of those are just small apps which are service focused, as well as actually some bigger analytics pieces where we're able to extract the data from the platform and provide that data for analysis.
Thank you very much, Mark, and that's a very clear, comprehensive answer. So I'm going to move on now to our final presenter, and that's Xiao Song, who's a statistician from Public Health Wales, and is going to tell us about the Network Data Lab project, which is, I believe, Health Foundation. So over to you.
Thanks, Alan. I'm Xiao Song. I'm a statistician in the Research and Evaluation Division in Public Health Wales. This presentation is about the Network Data Lab programme. The programme is funded by the Health Foundation, and I'm gonna introduce how what the programme is and how it's been developing in Wales. So Alicia Davis, who is the Head of Research and Development in Public Health Wales, she led this bit. She was going to deliver this presentation today. Unfortunately, due to unforeseen circumstances, she can't be with us today. So I'll be trying my best to deliver as much information as possible. As you guys can see, the list of all our collaborators here, I would like to take this opportunity to say a big thank you to Helen. She put a huge amount of efforts to pull everyone together to develop this bit. This is not particularly easy bunch of people have the availability to sit in the same room regularly for a period of time to develop the bit. So thank you, Helen. Can I have the next slide, please? So what is the Network Data Lab programme? It's funded by the Health Foundation. The Health Foundation has the principle to improve health and healthcare for people in the UK. And the programme itself is funded on the basis of collaborative network or infrastructure of analytical teams across the UK. These teams will be working together on shared challenges, promoting the use of linked data and analytics to improve health and social care. So the programme itself, it was not set up specifically for the COVID response, but the network is formed just in time to tackle some challenges around COVID in Wales and beyond. The funding call came out October last year, which is a year ago now. And there were 5 partners awarded, which I will introduce later. The program itself will run from October this year, which is now, for 2 years of time. During 2 years, all 5 partners will be answering same research questions on 3 key topics. Can I have the next slide, please? So these are the 5 NDL partners. There is one in Scotland, led by Aberdeen Centre for Health Data Science, which includes NHS Grampian and University of Aberdeen. There are 3 in England. One of them is led by Imperial College Health Partners in London, and one led by Liverpool CCG, the Clinical Commissioning Group, and one led by Leeds CCG. The last one in Wales, which is led by Public Health Wales, together with UNWIS, which is NHS Wales Informatics Service, Sale Data Bank in Swansea Uni, and Social Care Wales. Next slide, please. So when we came across this funding call, we just sat down and thought through about what we can provide to the NDL program and what we can benefit from it. So in terms of our strength, we have multidisciplinary, multi-professional teams across Wales, loads of expertise in linked dataset and also its application to health. We also have a dual platform approach to access linked datasets. Those datasets are not just limited to health, but also administrative data, social care, housing, education, wider determinants of health, which enabling this to span the boundaries of health to some focus on the inequalities. In terms of the dual platform, one is Sale Data Bank in Swansea Uni, and Rich had introduced a lot of the work they were doing during COVID, and the other one is the National Data Resource in UNWIS. And also we have strong links with health systems and also policy making across Wales. And we don't view researchers, policy makers, practitioners, clinicians, and so on in isolation. And in terms of what benefits we can have joining the NDL program, it's always good to have additional capacity to work on mature linked data resource in Wales to maximise the use of linked data. And also the program itself brings together advanced teams of analysts to use linked data to produce timely and responsive insights in critical areas of population health to inform action, bridging between research and implementation. And I also think there are loads of opportunities of sharing and learning across the program. So next slide, please. So this diagram roughly gives an idea of how NDL Wales will work. As I said, for 2 years of time, all NDL partners will answer the same research questions on 3 topics. The topic selection process is facilitated by the Health Foundation with inputs from all NDL partners, patient and public engagement activities, and our steering groups. So in Wales, we will apply the dual platform approach to access linkable datasets with information governance approvals in place. And we will also be sharing the findings with House Foundation and other NDL partners, enabling federated analysis where possible. So individual level data will stay where they are. We're not sharing any individual level data with anybody. Also, so the insights from the analysis will feed straight to our local priorities to support the decision making. Next slide, please. So this is the structure of the first analysis across all NDL partners. The key topic has been identified, which is the shielded population. I will go into more details in the following slides on the topic. So all NDL partners will answer the same questions to the topic, but at the same time, each partner has the autonomy to set up one satellite project related to the topic, but relevant to local priorities. So these satellite projects are different across the NDL partners. And next slide, please. So there was a survey from the House Foundation about 3 months ago to all NDL partners. The aim of the survey was to understand the local priorities for each partner. When we talk about local priorities in Wales, we're talking about what we are focusing on in Wales for the residents in Wales. So majority of the partners highlighted the need to understand more about the needs of shielded patients and the impact of COVID. That includes the understanding of potential unmet needs of this population group as a result of reduced or limited access to health and care services while they were shielding, as well as the inequalities experienced within this population group. Also, many partners identified the impact of COVID on mental health as priorities. And the other area was the understanding the reduction in the use of emergency care by different conditions. That was highlighted. Also understanding the differences in patterns of use across different socioeconomic status. It's another area identified by a number of partners. Can I have the next slide, please? So the questions we asked from Wales' perspective were how to identify most vulnerable, what is the healthcare needs among this population, that includes before and during the pandemic, and what are the indirect impacts of COVID to the most vulnerable. So that includes, for example, employment, education, and also impacts on those in the same household. Could I have the next slide, please? So in terms of decentralized analysis for 5 NDL partners, we will all start to explore the demographics of a shielded population respectively and try to understand the health needs before and during the pandemic. We believe there could be differences in health needs or even demographics of shielded population in different areas across the UK. Join a UK-wide picture to understand the health needs of this group. It's vital to move forward and support future planning. It will also contribute to the evidence base to support the future development on the topic of shielded patient. For example, the 4-nation approach of the risk stratification algorithm. Next slide, please. In terms of the satellite project in Wales, reflecting on the scoping with groups of our stakeholders, we pinned down the topic to understand the mental well-being and the mental health needs for shielded children and children live in households with a shielded person. Next slide, please. Just a few final points here I would like to mention. So even though both the NDL program and the analysis are only just starting, there were a huge amount of efforts being put in to identify key areas or topics. As partners, we are constantly debating on how to tailor the research questions and how to proceed with them. My favorite quote here is not precisely, but that's how I remember. Most of the time, what is slowing science is how science is created. Along the way, we are reflecting on what we have done and what we can do better by pushing the boundaries of data science and mulling over or thinking through the approaches to connect the dots between research and implementation. And COVID actually demonstrated how quickly some changes can happen. My personal favorite two are the community response to COVID and the voluntary spirit. So we believe COVID highlighted some real needs for changes. It is critical to understand these needs, but more importantly, we need to think forward, like how we can create these changes and sustain them. I think I'm going to stop here. Thank you for listening. Oh, by the way, we will be recruiting an analyst to join us in NDL Wales. So if anyone is interested, watch the space.
Jiao, thank you very much for that very thoughtful end. It is quite thought-provoking what you said there at the end. The one thing I would say is don't you come into Cardiff and Vale and try and pinch any analysts because I'm trying to build the team up there. So any questions coming through for Jiao? I liked the way you referred to the four-nation approach there, Jiao. It already sounds like a historical term, the way things have been going.
I know. I would like to know more about that.
Yeah. Okay. Any questions coming through, Helen?
No, I haven't got any questions right now.
Okay, fine. Well, look, again, contact details, I think, will be available afterwards for those that have questions. We've not done too badly for time. We're 5 minutes over, which, given our technical hitch in the middle, I think is pretty good going. I'd just like to sum up and give any of you a chance to think of any more questions in the last 2 or 3 minutes. I'd really like to thank all of the presenters, and I genuinely mean this. I don't know how many of you in the audience or how many of you who are watching this on the YouTube recording have had to do a presentation like this remotely in a virtual environment. I had my first experience of doing it a couple of weeks ago, and it's really difficult and very challenging. There's no audience feedback. You don't know whether you're talking to one person or 301 people. And I'd really like to thank the speakers. And I think I'd also like to thank you for attending and watching. Because the thing is, I think we've all realised that this could be it for many, many months ahead. You know, the thought that we might be getting back to those nice networking events with coffee and pastries, that's not happening anytime soon. And it remains really important to collaborate with others, to hear about who's doing what across Wales, have a bit of context for what you're doing in relation to what other people are doing. And I think it makes these sort of webinars really important. And certainly in my own mind, just reflecting, listening to today's, really interesting. And I've missed this. I've not done much of this in the last 3 or 4 months. So I'll certainly be making an effort to attend more sessions like this. I'm hoping that the DHEW will be putting more events on. I'll certainly be trying to attend. Any final questions? Okay, in that case, I'm going to wrap up. Helen and the team at DHEW, can I just say a big thank you to you? I was really, really delighted to be asked to chair it. As I say, I would have been attending anyway. And thanks very much, and see you next time. Okay, bye everyone.